we move on to the very important talk, a newer technology, information and knowledge, and we are all looking forward for it. Michael, please go ahead.
Okay, thanks, Ale. It is a pleasure to be here. Thank you to the Indian Society and thank you to Alcon for putting this symposium on. My talk is on understanding the Vivity lens, what they're calling the X-wave technology, and I'll talk a little bit about how the lens works and how it's impacted my practice and a few small number of cases. I'm a consultant to Alcon and to Carl Zeiss. I won't labour this. If you've been Arup spoke at length about the change in presbyopia lens technology over the years. And I would just say that this is different. This is, in my view, not a multifocal, it's not an EDOF, it is a different lens. It uses these two transition elements, which I'll go into, to create an advanced and a delayed wavefront to give a continuous extended focal range. And it has full light utilization, so therefore a monofocal visual disturbance profile. There is no light splitting, whereas any multifocal or trifocal has to split light in some way to perform its task. But this does not occur with this lens. And so the monofocal visual disturbance profile is real. The downside of this lens is that you will not get true spectacle independence. It's like this, and I've actually put the US patent number there. You can go and look into that patent via Google Patents and dig into the detail of how the lens works. It was patented in May 2018. But there are two transition elements which stretch and shift the wavefront. It's a simultaneous action, delivers a continuous extended focal range. And on the left-hand side, you see this little 1 micron raised area, and this area is 2.2 millimeters, and that's raised 1 micron. And there's another slide which shows that a little bit better. If you look with the naked eye, a Vivity looks exactly like a Acrosoft. No difference, it handles the same way. You can't tell them apart. This is a Vivity being placed by me using an automated injector. It behaves just as we're familiar with an Acrosoft. You see here though, this is at the end of the procedure, you just see the little ring there centrally, and then I move the light, that's the same eye, like 10 seconds later, and then you can't see it. So you have to get the transillumination right in order to actually see that this is a Vivity lens, because that lens right now is a Vivity, but you couldn't tell from that angle. But my point is that it behaves exactly like a lens that you're familiar with. And that's 1 week post-op, and you can just see in the pupil there, the little edge of the 2.2 millimeter ring, the pupil's constricted under the operating microscope. I just flicked over to that eye as I was doing the second eye. And you can see that just as you can see it on the slit lamp, but you can't see it with the naked eye. So the patient or a patient's relative can't see this as a different lens. If you magnify it up, you will see that how this lens works. There is this 2.2 millimeter central zone, which is its distinguishing feature. And that surface transition element, that the 1 micron high ridge or plateau stretches the wavefront, and then the 2.2 millimeter region centrally with its small curvature change across that central 2.2 millimeter range shifts the wavefront. And so by doing that, you get to use all the available energy. It's not 88%, it's 100%, or as much as a lens can give 100%, as a monofocal does. I find this a really helpful slide. On the top, this is like a equivalent of a modulation transfer function, but the monofocal has a excellent light intensity distribution at distance, but it fades off at intermediate and near, as we know. The AT Lara, the Zeiss lens, that was my go-to EDOF lens, and I still use it. I think it's a really good lens, has very clear vision, but it does have some parts because it's effectively a multifocal lens where the light is missing in effect or degraded. Whereas the Vivity, which is the bottom, shows really a monofocal profile in terms of the intensity of light, but it continues past the intermediate towards the near. So up until recently, a traditional monofocal gave good distance, we know that, but poor intermediate and near. A modern trifocal like the Panoptix gave the best chance of true freedom from glasses at all ranges, and in my view still does, but at some cost, modest costs in quality of vision, because all multi and all trifocal lenses have to split light. And those EDOF lenses are the in-betweeners, where you're not quite good enough for near, but you get some photic phenomenon. So with Vivity, those options do expand. It extends the range, but does retain good, clear optics. It also does offer a seamless transition, and this was a surprise to me. The patients don't have to hunt for the correct focus point. It's a really nice transition seamlessly from distance to intermediate and a little bit into near if you offer some mini monovision. So you have a choice, and this has made my patient conversation quite easy these days. Choice one, aim for plano in both eyes. That gives a patient good unaided distance and intermediate vision, but they will wear readers at about a +1 level. Simple, a lot of people will opt for that option. Choice two is a slight offset in the non-dominant eye. And by that I mean a -0.5 to 0.75 in the dominant eye. That actually gives quite a reasonable chance of freedom from reading glasses, but not for everybody and not as much as a trifocal, so you can't promise it. But it does give you an ability to fudge the end point for a patient who likes a little more spectacle independence, but still does not want photic phenomenon. And this is not monovision. This is not one eye doing one thing. Both eyes are working together, and the extended range of the Vivity does offer this visual summation. It's a very natural type of vision. And obviously choice three, which I won't go into this talk, is if you want spectacle independence, that is the most important thing to you, then really it comes down to a Panoptix. Now I'm indebted to Francesco Cronius, who many of you would know, a terrific Italian doctor from Milan, for this slide. And what it shows is the good and bad of Vivity. Now this is where he's got 20 eyes, bilaterally implanted, plano in one eye, -0.5 in the non-dominant eye. And this is their degree of spectacle independence. The black areas are where they're not free of glasses. And so if you see they're reading in the dark, about 30% of patients have to wear glasses. And that is a reflection of this lens. With mini monovision, you'll do great at distance, at intermediate, and into the near range, but in poor quality light or for prolonged reading, you are going to need some help. So you can't overpromise with this lens. But remember, there are no photic phenomena. And that's what makes this lens different for patients and for ophthalmologists. The quality of vision is equivalent to a monofocal. The photic phenomena are the same as a monofocal. That's in the FDA data. It's in the Vivity registry that's being done around the world. And that's certainly true in 18 months of practice with this lens that I've managed to have. There are no visual gaps, it's seamless, and a slight myopic offset is available to you to give a little more independence. And in my experience, that's the first time a lens has been able to give all of the above. So 3 cases. This was one of my first cases back in December 2019. And I was trying to work out, I didn't quite believe the data. I'm old enough to be suspicious about data sometimes. So I put a Clarion in the left eye, the dominant eye, and a Vivity in the right eye, aiming for -0.75. He was 63, had some cortical cataract. And I got him just right. And I'm just going to dwell on this slide for a moment because I got him right. The Clarion eye, 6.4.5 unaided, perfect distance vision as planned. In the right eye, we got him to -0.75. That's great. And he corrected up to 6.5. But that's how this left eye is the Clarion, so a monofocal lens. At intermediate, at 66 centimeters, he's reading N10. At near, he's reading N12. That's what a monofocal does. The Vivity at minus 0.75 is a little forgiving because he's seeing an easy 6, 7.5 because there is a little bit of give in this lens for small refractive errors. At intermediate, he's reading N5. You'd say, well, okay, I can get that with a monofocal with minus 0.75. And near, he's minus 0.75. Now, what the lens is doing, it's giving you, he's minus 0.75, but it's giving you about a diopter or a diopter and a quarter. So he's reading it near the equivalent of a minus 2. And so that is how this lens works. This patient allowed me to move on and be a bit more aggressive. And so this is a second case. This is a patient with keratoconus. Not too bad. That's the topography as you see there. I would never, in the old days, put anything other than a monofocal or a monofocal toric sometimes in that patient. I would never have put a EDOF or a trifocal. But I put a Vivity in the left eye, and he's great. He's 6.7.5 unaided, corrects with a small refraction to 6.6. Very happy with the quality of his vision. His intermediate and near is not perfect, but it's a little better than he would have got with a monofocal. But importantly, a compromised cornea and a multifocal eye will give you 2 hits against visual quality, 2 chances to have increased aberrations. Whereas here is a compromised cornea, but a lens which is behaving like a monofocal in terms of quality of vision and photic phenomenon. So you can put it in compromised eyes, and obviously that applies to a lot of post-refractive eyes as well, post-LASIK eyes. Last case, bilateral cataract, more dense cataract, an older patient at 73, and got an aim for plano, was a little bit more minus in the right eye, really happy. And sometimes you see this patient is truly free of glasses for everything, slightly smaller pupils than average, and that does tend to help. But what I want to just show you is the QVID quality of vision validated questionnaire. Preoperative, this patient had quite dense cataracts, had plenty of halos and glare and lousy vision, and postoperatively had 0 quality of vision issues. Now that's rare to see 0 even in a monofocal patient where you've got them plano. So I actually thought, oh, they made a mistake. So I got them to retest the patient. No, 0. And this patient, I just put that one up to demonstrate. Now some patients with a monofocal and a Vivity will get some occasional symptoms, but they're equivalent. So with this lens, you do not have to be worried that you're going to induce photic phenomenon. You have a lens which does all these things, the monofocal profile, but the added advantage of adding in a diopter or a diopter and a quarter of an equivalent near and intermediate effect. And this lens, in my experience, after 18 months of use, has now become effectively my default lens. I have to find a reason not to use it. And sometimes I do use a monofocal, sometimes I do use a panoptics, but I have to find a reason not to use this lens rather than to have to find a reason to use this lens. So it's my go-to lens these days. So thank you very much for having me as part of this symposium.